Good evening, doctors and all participants. Welcome. I'm Dr. Rizin Kusop, the Secretary of APS. Welcome again to our free live streaming webinar brought to you by the Association of Private Practitioners Sabah. And as usual, during the session, if you have any question, please write them down on the comment section of the YouTube platform, and they will be addressed by the speaker at the end of the session. Please write them early. Don't wait until the end so that you won't lose any train of thought while listening to this talk. It's my pleasure to introduce you this evening our speaker, Dr. Tan Sor Eun. Let me introduce Dr. Tan to you a little bit. Dr. Tan graduated from University Malaya in 2009 and subsequently obtained her Master of Surgery in Ophthalmology in 2017. She first worked in Queen Elizabeth Hospital in 2009 before moving on to other hospitals in Malaysia such as in Selayang Hospital, UMMC, Sultan Ismail Hospital, Johor, Hospital Shah Alam Selangor, and currently practicing privately at iMedic Clinic here in Kota Kinabalu, Sabah. She has involved in various academic publications. As you all will see in her CV listing later on, we will post it in the group. The topic she will be delivering today is refractive surgery. Ladies and gentlemen, doctors and colleagues, Dr. Tan Sor Eun.
Hello, good evening, everyone. My name is Dr. Lisa. I'm an eye specialist in iMedics Specialist Eye Center, Kota Kinabalu, Sabah. Today's talk will be on refractive surgery, a review of current treatment options for presbyopia. I already had a pre-recorded presentation, which will be played later on. I'll be addressing your questions at the end of my presentation. Hello, good evening, everyone. My name is Dr. Lisa. I'm an eye specialist from iMedics Specialist Eye Center, Kota Kinabalu, Sabah. Today's topic will be on refractive surgery, a review of current treatment options for presbyopia. And before I go into further, I would like to thank the organizer for giving me the opportunity to share some knowledge on this platform on the various methods of optical corrections that's currently available in the market for the presbyopes. I have no financial interest. These are the sponsors for today's talk. So what is presbyopia? Presbyopia is a common age-related vision disorder characterized by a progressive inability to focus on near objects. The loss of accommodation, the mechanism by which the eye varies its refractive power to focus on objects at different distances to provide the retina a clear, sharp image, is a natural part of a lenticular aging process and the first stage of dysfunctional lens syndrome. Helmholtz proposed that the eye's circumferential ciliary muscle contraction releases zonular tension, allowing the lens capsule to contract, increasing lens surface curvature and thus providing the dioptric power necessary for near visual tasks. This ability is reduced as the lens stiffens and becomes dysfunctional with age. Globally, there are an estimated 1.8 billion people with presbyopia. The burden of uncorrected presbyopia is significant, accounting for near vision impairment in an estimated 800 million people globally, resulting in an estimated 25 billion loss in productivity among individuals younger than 65 years. With increasing longevity, Most people in the world will spend almost half of their lives as presbyopes. It is a condition that results in loss of productivity and also quality of life, and it may create safety concerns, suggesting it should be treated as an important medical need rather than as a lifestyle decision. And as such, there is an increasing demand for surgical options for relative spectacle independence at all distances. This table shows the different ranges of accommodative amplitude at various ages and for different refractive errors. Accommodative amplitude of accommodation is the amount of accommodation exerted to move the focus from the far point to the near point. It decreases from childhood to 65 years. As a person ages, the ability to accommodate diminishes, resulting in presbyopia. As you can see, emmetropes are people with no refractive error, myopes are people with short-sightedness, hypermetropes are people with far-sightedness. As you can see, from the age of 40 to 50 years old and beyond, among the three, hypermetropes are usually the ones that we present earlier or manifest the effects of presbyopia earlier compared to the rest, as their accommodative amplitude reserves depletes much faster and earlier compared to the rest. And before I dive into the topic proper, I would like to introduce this term called dysfunctional lens syndrome. This terminology was introduced by Dr. Daniel Dury, Dr. Jason Starr, and Dr. George Waring to describe the aging spectrum of the crystalline lens and to guide surgeons with decision-making in the surgical correction of presbyopia. It provides an objective assessment of lens density and intraocular scatter, and it is useful in diagnosis and also staging of the lens dysfunction. The diagnostic evaluation described may be used to differentiate refractive surgery-seeking patients based on qualitatively and also quantitatively evaluating the lens status, and also to help determine who is best suited for corneal procedures such as PRK, LASIK, or SMILE, versus those who are better suited for replacement of dysfunctional lens syndrome by performing a refractive lens exchange. And there are three stages. Stage 1, 40 to 50 years old are usually clinical present with purely just presbyopia. Stage 2, 50 years and above with increasing lens opacity and also ocular aberration. And stage 3 with clinically they will present with visually significant cataract with manifest opacity and also higher order aberration. Picture on the right side of the screen shows a slit lamp examination of the anterior segment of the eye with a visually significant cataract, while on the left side of the screen shows anterior segment, a cross-section of the anterior segment of the eye showing the increasing in opacity and also density of the crystalline lens in descending order, which correlates with the higher the opacity of the crystalline lens correlates with the increasing in lens ocular scatter index. And in stage 1 dysfunctional lens syndrome, it is proposed that the potential treatment option would be a corneal-based procedure such as a Presbyopic Lasik, whereas in stage 2 and stage 3 where the lenticular increasing in the density of the ocular crystalline lens, whereby a lens-based procedure would be much more suitable, such as a refractive lens exchange. Scientists have categorized 4 major groups of treatments based on the different type of mechanism of action on how we are able to recreate or to replicate the depth of focus that we used to have when we are in our youth. There are 4 methods. The first one will be varying refractive power over time. The second method would be varying refractive power across a different visual field. The third would be a varying refractive power between the eyes by employing monovision. The fourth would be varying refractive power across a range of distances. The first method would be a varying refractive power over time. One such example would be spectacle, which is the simplest method for changing the refractive state over time. While using different glasses for far and near visual tasks, mechanistically varies the refractive power over time. Non-surgical approaches includes an eye drop that exerts ciliary muscle contraction as one of its mechanisms for accentuating accommodation. Another pharmaceutical option which dissolves disulfide bonds in the lens, returning the lens to a more flexible state, thereby allowing for natural accommodative ability. Other options such as laser options include scleral laser microexcision, which uses lasers applied to increase the scleral plasticity and compliance of the scleral tissue to facilitate contraction of ciliary muscles. Last will be accommodating intraocular lens, which are intended to create a progressive change in power in relation to active contraction of the ciliary body. The disadvantage of this method would be, at the moment, there is no drug or device demonstrating true refractive change over time has received approval from the US FDA. With no current FDA-approved presbyopia treatment in this category, it is not possible to assess the safety and also the efficacy. The sole intraocular lens so far to receive approval from FDA is the accommodating intraocular lens, which is by the Bausch & Lomb Crystalens intraocular lens. However, this lens has its drawbacks, which this lens demonstrates limited objective accommodative response movement on aberrometry. The second method would be varying refractive power across visual field. For example, by employing multifocal glasses or multifocal contact lenses. And broadly speaking, near visual tasks such as reading are typically performed in the lower visual field, while far tasks such as driving, watching television are performed using the central and upper visual field. Optical devices have been designed to leverage on this tendency by providing different refractive power corresponding to the direction of the gaze. Multifocal spectacles, for example, and also multifocal contact lenses are using this method to increase the depth of field. The disadvantages of this method would be multifocal specs may require head and body movements when trying to focus on objects at different distances, and they may contribute to image jumps and also distortions. Decrease in edge contrast sensitivity and also depth perception in the inferior visual field, making it difficult to judge objects' position and also movement. And this has shown to significantly increase the risk of accidents and falls in the elderly. The third method would be varying refractive power between eyes by inducing monovision. So in monovision, the dominant eye is corrected for distant vision, while the other eye is intentionally left nearsighted to allow you to see close objects. With this method, both eyes work together, allowing us to see clearly at any distances. There's various methods that can be employed to create monovision, such as contact lens monovision, Monovision Lasik, PRK, or SMILE. You can also utilize intralenticular base would be intraocular lens monovision. The disadvantages of this method would be, although monovision is relatively easy to implement and work for many individuals, but it might not be tolerated by some. Success with monovision is dependent on suppression of interocular blur. Incomplete suppression may be a safety concern, as monoocular blur increases the risk of falls as patients will perceive double images. Monovision is frequently associated with a reduction of peak visual acuity, loss of contrast sensitivity, and also compromise in stereo acuity. It also negatively affects quality of vision at all ranges and depth perception. As a consequence, it may not be suitable for patients in whom binocular vision and depth perception are particularly critical in their career or lifestyle. This also limits the use of monovision in patients requiring good stereo acuity, like professional drivers or pilots or surgeons, etc. The fourth method would be varying the refractive state of the eye across a range of distances. Refers to the creation of simultaneous focus through far, intermediate, and near. An example of these are like small aperture cornea inlays, small aperture intraocular lens, presbyopic Lasik, implantable contact lens, and also multifocal intraocular lens. With this mechanism, objects at all distances appear simultaneous focus, and thus continuity across the field of view and also between eyes is preserved. Multiple methods can be used to achieve pseudo-accommodation. They can be categorized by the optical principle, leveraged to increase the depth of field via small aperture optics, refractive optics, and also diffractive optics on the cornea or on the lens. Small aperture optics, or the pinhole effects, extends the depth of focus by blocking unfocused peripheral light rays and permitting only central light rays to reach the retina. An example of this would be the pinhole intraocular lens or a pinhole cornea inlays. Refractive optics. Refractive optics utilizes various zones to focus incoming light rays from different distances to create a broader range of focus on the retina. An example of this would be contact lenses, cornea refractive inlays, and also refractive intraocular lens. Diffractive optics creates a phase shift of the incoming wavefront to create an expanded range of focus so that objects at different distances appear in focus. For example, a multifocal contact lens, a presbyopic Lasik, and also multifocal intraocular lens utilizes these diffractive optics. The disadvantages of these methods will be only two, which is a compromise in visual quality and also the incidence of bothersome low light dysphotopsia, such as glare, halos, and stubbers. And in conclusion, there are 4 commonly employed surgical methods to correct presbyopia. One would be a monovision Lasik, which is a cornea-based procedure, and presbyopic Lasik, and it is also a cornea-based procedure, whereby another method, which is a more lenticular-based, would be presbyopic implantable contact lens or a refractive lens exchange. Monovision Lasik or PRK is performed by adjusting the residual refractive error to create a low myopia in the non-dominant eye to aid near vision. By this, one eye is utilized for distant vision and the other eye for near vision. Though it is easier to plan and perform, loss of fusion and also stereo acuity are the main limitations of Lasik or PRK monovision. This limits the use of monovision in patients requiring good stereo acuity, like professional drivers or pilots, surgeons, and etc. Presbyopic Lasik is a technique whereby cornea is ablated using multifocal ablation profile to correct ametropia and also presbyopia. This works by creating a corneal multifocality and increasing the depth of focus. With this approach, the same eye is utilized for both distance and near vision and is more physiological. Unlike monovision procedures, both the eyes are adjusted for near and distance, providing a good stereopsis. Among corneal procedures, Presby Lasik has been gaining popularity based on how the multifocality is created. It is classified into three major types. Number one would be the central Presby, a peripheral Presby Lasik, and also laser blended vision. Most techniques of Presby Lasik currently employ a hybrid method, which is a component of monovision added on to a multifocal corneal ablation. Presbyopic implantable contact lens is an option for surgical correction of myopia and also presbyopia, which spares both the cornea and also the crystalline lens. It is an additive procedure whereby a implantable columnar lens is inserted into the eye and can be removed if needed to. The ICL has a favorable safety profile with no significant loss of best corrected visual acuity and no decrease in contrast sensitivity. Refractive lens exchange is a surgical procedure whereby a crystalline lens is removed and replaced with a multifocal intraocular lens implant, which corrects existing refractive error in addition to presbyopia. So this is a simple algorithm that we follow when a potential refractive candidate in the presbyopic age group presents to us for a refractive surgery consult. Based on the diagnostic imaging, screenings, and also clinical examination, we will then determine whether a patient will fall under a corneal-based or a lenticular-based procedure for the correction of presbyopia. If the patient has normal dysfunctional lens index, patients are usually counseled for a corneal-based procedure or a phakic intraocular lens. Depending on the corneal topography of the patient, if it's normal, patient will most likely be counseled to go for a monovision LASIK or a Presby LASIK. And if the corneal topography is abnormal or suspicious, patient will be counseled to go for a phakic intraocular lens procedure. If the dysfunctional lens index is impaired, patient will be counseled for a lenticular-based procedure such as a refractive lens exchange with a multifocal intraocular lens or a monofocal lens, utilizing a monofocal monovision. And this is a video on phakic implantable columnar lens, which is now also available with presbyopic ICL. And I've come to the end of my talk. Thank you very much for your kind attention. And before I conclude my talk, I would like to speak a little bit on dry eye treatment. And because of today's talks is sponsored by the Alcon and also Suntan, I would like to speak on the different eye drops that's available for the treatment of dry eyes. Cystine is a known brand of artificial tears that can be used for the treatment of dry eyes, and there are various types of cystine, and it is important to understand the key differences and benefits of each product. The first one will be Cystine Complete. And Cystine Complete uses advanced technology to optimize moisture and also improve dry eye symptoms. It contains HP guar, which has been shown to improve dry eye symptoms. The nano-sized lipid droplet over the eyes help to minimize blurring on installation and improve spreading across the eye, covering more surface than the conventional eye droplets. Watery layers is replenished. Tear film is stabilized to prevent evaporation. This offers rehydration and also protection to all layers of the tear film. Cystine Complete eye drop can be used as needed for the treatment of dry eyes throughout the day. They can also be used before and after wearing contact lenses. Shake well before using. Instill 1 or 2 drops in the eyes as needed and blink. The second would be Cystine Hydration. Cystine Hydration provides additional moisture to the eye and is recommended for people with dry eye symptoms who need lasting relief, often associated with contact lens wear, medication, or allergies. The unique combination of HP guar hyaluronate acts as a dressing on the eye to restore damaged cells on the eye surface and provide better protection for the eye. Cystine Hydration works by triple action, enables a higher degree of rehydration and lubrication of the eye than hyaluronate alone. Ketonome, which is the yellow color box here, is an emulsion formed by aqueous phase and oily phase. The main component of oily phase are mineral oils. Its advanced formulation not only restores moisture but also helps to prevent fluid loss. Indication for ketonome use would be relief, discomfort, and also eye irritation due to dry eye caused by prolonged use of contact lens and also environmental condition. The second one would be Daikwas. Daikwas is a topical cyclosporin used in dry eyes associated with keratoconjunctival epithelium disorder, accompany lacrimal fluid abnormality. The mechanism of action is that it stimulates water and mucin secretion on conjunctival epithelial and also goblet cell membrane. The fourth will be Icavus. Daikwas is actually not a topical cyclosporin. Daikwas is actually a secretagogue that stimulates water and mucin secretions on conjunctival epithelial and goblet cell membrane. While Icavus, which is a topical cyclosporin, its therapeutic indication is for severe keratitis in adult patients with dry eyes, which has not improved despite treatment with tear substitute. And that's the end of my talk. Thank you.
Thank you, Dr. Tan, for that very informative and interesting presentation. We don't have question yet at the moment, but let's discuss a bit about this topic. It is very interesting and very personal to me as well, as I mentioned to you before during our informal chit-chat that I had LASIK many years ago, and it was actually a pleasant experience for me. So as a GP, and I think most of us will be asking the same question is, what would you advise to us? How do we assure our patient who are asking us whether they should go for refractive eye surgery or not. A common patient who doesn't know anything about eye, doesn't know anything about surgery and stuff. How do you think we GP go about giving them assurance that this is actually a very safe operation on the eyes?
Okay, I think it is better to ophthalmologists to counsel all these kind of patients, because it is very hard to determine whether is this a patient a candidate for refractive surgery or not. First and foremost, everybody's eye is different, so depending on what the patient wants and desire, and of course, in the first place, the patient has to be fulfill the requirement as a candidate of a refractive surgery, such as we have to make sure that the patient has doesn't have a dry eye in the first place. And the second thing is that what we look for a patient who wants to go for a refractive surgery would be to look for whether patient is a candidate or not, such as whether the corneal thickness is it adequate for a refractive lens exchange to take place. Then the various diagnostic imaging that would require to see whether patient suitable for a corneal base or a lenticular base refractive surgery. And of course, today's topic will be mainly on presbyopia. So if you talk about patients who are in the age group of 20 to 40, which is purely patient, if they come for a refractive surgery consult, is basically they trying to correct their ametropia, which is most commonly to treat their short-sightedness. And for those patients with more than 40 years of age where the presbyopia has already takes place, then patient would it's the same thing. I mean, we would refractive surgery would have correct their ametropia plus their presbyopia. So as I said in my presentation, patient there's a few options. So one of the option would be a Monovision Lasik or a Presby Lasik, which is both of them are cornea-based surgery or procedure, or patient can even consider to go for a Presby ICL, an implantable contact lens, which it used to be only available for the treatment of ametropia. But at the moment, we have presbyopic ICL, which is available to correct ametropia and also presbyopia. And fourthly would be a refractive lens exchange. But refractive lens exchange is only suitable for those people who had mild lenticular changes, such as a mild cataract and beyond. And refractive lens exchange, what we do is that usually we remove your crystalline lens and then we replace it with a multifocal intraocular lens to treat your ametropia and also your presbyopia.
Thank you for that explanation, Dr. Tan. To summarize it, I think it's better for us GP just to refer the patient to ophthalmologist, as we have heard from Dr. Tan. That is actually a lot of criteria and a lot of what do you call
diagnostic imaging that require to screen for.
Exactly, a lot of things they need to do to assess the patient whether they are qualified for certain operation procedure and whether that operation is actually dangerous or not for them. Usually we GP are asked whether it's worth going or whether it's dangerous or not. They wouldn't bother asking about all those detailed procedures. So for me it's easy because I've done it before. So I just told them that I've done it 10 years ago and look at me, I'm okay. I don't need spectacle and I've been doing all sort of things, swimming and everything, and it's all right. But I can imagine for those patients who are those GP who are still wearing glasses and patient asks them, and it'll be quite difficult for them to explain. But I think, as Dr. Tan mentioned, it's better just to refer them to the nearest ophthalmologist for the patient to get a proper advice and assessment. All right, we still haven't got any question yet. My next question is, as usual with procedures like this, patients are also very interested to know the rough estimate of cost. Last time during my time, it was 5,000 ringgit for both eyes, and it was quite expensive then. But I think it's reasonable if I think about it with the quality of life that I had after the operation. So probably Dr. Tan, you could give a bit of rough estimate of how much all this procedure and cost and everything.
It depends on what type of LASIK that you are looking at. So there are two types. One is non-customized. Another one will be a customized LASIK. So for those non-customized, usually it cost ranges per eye. We are talking about nowadays. You can go as low as 1,500 per eye. And if you opt for the customized LASIK, it will ranges from anywhere from 3,000 to 4,500
per eye.
Yeah, per eye. Yeah.
All right.
So for ICL at the moment, in iMedics, we do not have LASIK machine yet, but that's something in the future that we are looking at. Is already in the pipeline. So what we are offering at the moment in iMedics is that we have implantable contact lenses, which is available to treat ametropia for those patients from the age group of 20 to 40. And from 40 and above, we do have what we call it a presbyopia ICL. And then also we do refractive lens exchanges as well for those people who desire spectacle independence to treat their ametropia and also presbyopia.
Thank you. We got one question from Dr. Nazri. Hi, Dr. Lisa. Thank you for your very informative lecture. May I know, is there any role of Cystine or other artificial tears in allergic eye?
Allergic eye. Usually in allergic eye, we will treat with some topical antihistamine eye drops. But role of cystine, but cystine and other artificial tears doesn't really counter the problem in allergic eye mainly. So we do not use artificial tears in patient presents with an allergic eye. Usually we treat with antihistamine, topical antihistamine, such as Patade and also Allergo.
Yep. Thank you. Next question is from Dr. Lau. What is the difference between LASIK for the short-sighted and for the long-sighted?
Oh, what's the difference between LASIK? I mean, LASIK is just a procedure. Usually it can be used to treat for short-sightedness and also long-sightedness. All right. If I'm not mistaken, what you're trying to ask is that is there a treatment for hyperopic in presbyo? So in my presentation, LASIK can be utilized or can be used to treat your short-sightedness or your long-sightedness plus your hyperopia, which we call it the presbyopic Lasik. And for those people who present with 20 to 40 years of age, let's say if you're long-sightedness, LASIK can be used to treat your long-sightedness as well.
I think what Dr. Lau is asking is how can be the same procedure used to treat different condition of the eye. From my experience last time, I think it's the way they actually ablate the cornea.
Yes.
Correct me if I'm
Short-sightedness, usually we flatten your central cornea. As opposed to long-sightedness, which is hyperopic LASIK, we sort of like steepen your peripheral cornea. If that's what he's answering.
Yeah. Basically, how you cut your cornea to refract.
How to reshape your cornea.
Exactly. I hope that answers his question.
Yeah.
All right. Still no question at the moment. We wait for a little while. And let me address the participants here. Thank you for listening to us, participating. In a short while, our IT person will display the QR code at the end of the presentation. And please scan them with your MMA apps to get your 1 CPD point. If you have troubling scanning and getting the point, please register your name at the link given earlier on the WhatsApp group so that you can be registered to get the point as well, even though you didn't manage to scan the QR code. I would like to take this opportunity also to thank our Secretariat, Ms. Melissa and Mr. Adrian, for their assistance. Thank you to our sponsors, Cystine, Alcon, Santen, and Remedy. And also especially to Dr. Lisa Tan for her time to come here and give us a very informative overview about refractive surgery. Dr. Tan, is there anything else you want to share to our audience before we close this session?
I think there's nothing much.
No more?
Yeah.
I think the most important point that I got from this presentation is it's better just to refer the patient to ophthalmologist if they come asking about LASIK surgery. Yeah. All this time I've been using my case an example that is actually good, but listening to the presentation from Dr. Tan, I can foresee that it's not as straightforward and as simple as what I have undergone. So better refer to ophthalmologist, to the nearest ophthalmologist. Okay, thank you again, everyone. We'll see you in several weeks' time. The next topic will be bariatric surgery by a renowned surgeon from Gleneagle Hospital. Now, I know a lot of people, a lot of patients are also asking about this procedure because they want to lose weight. Bariatric surgery. See you again. Bye-bye.